Well, welcome everyone to the EKG case for the week of August 27th, 2012. We'll see if we can get this case up. There we go. So this week's case was brought to us by Andrew Bowman. Andrew is a self-confessed EKG nerd as well. He's an acute care nurse practitioner and paramedic working in Indiana. He works in the emergency department at Witham Hospital in Lebanon, Indiana, and also in the emergency department of Indiana University Health Arnett Hospital in Lafayette, Indiana, and he's been involved in emergency medicine services and emergency medicine for 30 years. So he is a very long-standing EKG nerd. So thanks for joining us, Andrew, and sharing this case. This is an 84-year-old woman that presented to the emergency department complaining of chest pain with radiation to the shoulders, neck, and jaw. Now, this is pretty much a slam dunk admission. There's no big surprise there, even without the 12-lead EKG. And so the history kind of gives this away. But the history doesn't always give us the diagnosis. Sometimes the histories can be very subtle. So let's pretend that the history is a bit more subtle. And taking a look at the 12-lead EKG was a subtlety that Andrew actually noted and predicted was a source of acute coronary syndrome, or a sign of acute coronary syndrome. This patient, based on the history, no surprise, got admitted to the hospital, ruled in for an MI, and quickly developed a troponin of 5. And I don't have a baseline 12-lead EKG or some subsequent EKGs for comparison, but the 12-lead EKG does show some things that kind of made me think it's probably worth talking about this subtlety. And again, Andrew was able to pick up on this. What you'll notice is a subtlety in leads V1 and perhaps V2, V3 as well, but I want to focus your attention on lead V1 again. And as in past weeks, I want to focus your attention on the T wave in lead V1. There is a relatively big, tall T wave in V1. It's also larger than the T wave in V6. Now, again, some of you are looking at this and saying, man, that's really, really subtle. Looking at the T waves in V2, V3, those are relatively large. What's the potassium here? It turns out the potassium was about 4. So this is not hyperkalemia. And there's a very simple take-home point that Andrew picked up on, and I hope to emphasize during this EKG video cast. When you see a relatively large T wave in V1, with a few exceptions, you should be concerned about the possibility of acute cardiac ischemia. So let's go through a few cases and really try to hammer home that simple point. Okay, it's not well studied. There's not a ton of literature about this, but some big name people in the emergency medicine, or rather in the EKG literature, have talked about this. Giants, for example, Henry Marriott and Edward Chung, and a few other people out there have talked about this, and I think it's worth knowing. So let's take a look, first of all, at a normal 12-lead EKG, specifically looking at the T wave in lead V1. Notice the normal T wave in lead V1 is inverted. Sometimes that T wave can be flat, but when that T wave is upright, and especially when the T wave is large, you need to worry that you may possibly be looking at a patient with acute cardiac ischemia. And also, if it's a new tall T wave, what I would like to refer to as an NTTV1, a new tall T wave in lead V1, that may be a sign of early cardiac ischemia also, if your patient has any type of symptoms at all. I guess the way you can think about this is that it is a type of hyperacute T wave. Now, everybody out there probably knows that hyperacute T waves, or tall T waves, can be an early manifestation of cardiac ischemia. But the reason why I want to focus your attention in this segment about this particular thing is that sometimes the hyperacute T waves are ignored because they only show up in lead V1, maybe in lead V2 also. So a new tall T wave in V1 can be a type of hyperacute T wave. And again, there's some literature out there put out by Henry Marriott and Edward Chung that talk about this. There's some people that believe it could indicate some prior underlying ischemia, but more concerning to us in the emergency department is that it is sometimes indicative of acute cardiac ischemia. It's a type of hyperacute T wave, and what you really need to remember also is that this new tall T wave may sometimes precede other expected EKG changes. Now, you may look at this and say, well, you know, that T wave that you showed us that Andrew sent wasn't all that big, so how do you define a tall T wave? Marriott and others have defined a T wave in lead V1 as concerning when the T wave in V1 is larger than the T wave in V6. And what he referred to that as was loss of precordial balance. Normally, the T wave in V1 is flat or inverted, but if it is upright, now maybe that's a normal finding, but when that T wave in V1 is upright and larger than the T wave in V6, you've lost T wave precordial balance, and that should be concerning for possible early cardiac ischemia. Again, it's a type of hyperacute T wave in many, many cases. So let me show you a few cases. This is the case that I really became convinced about this. This is a 61-year-old woman that presented to the emergency department with some pretty concerning symptoms. She's a slam dunk admission. She's got chest pressure, shortness of breath. Her symptoms improve with nitroglycerin. Her initial EKG is just non-specific. That was the formal interpretation. Non-specific ST and T wave abnormality. But what I want to focus your attention on for this segment, notice that the T wave in V1 is upright and it's larger than the T wave in V6. And that's not a normal thing. Here's the baseline 12-lead EKG, by the way. So you see that she has not only a tall T wave in V1, but it's a new tall T wave in V1, an NTT V1. So anyway, she's going to be admitted to the hospital regardless of that EKG, but there was no beds upstairs, so she stayed in our chest pain center, and that gave us an opportunity to do some serial EKGs on her. And here's what happened. This was the first EKG I just showed you a second ago. We decided to repeat the 12-lead EKG about 20 minutes later because her symptoms were persisting. Here's the repeat 12-lead, and you'll notice that the T waves in lead V1 and V2 are getting larger. Let me go back. Here's the initial EKG once again, and here's the repeat 12-lead EKG, taller T waves. So notice also there's not much in terms of ST elevation. The STs out here are starting to sag a little bit, but nothing's really diagnostic. 15 minutes later, now her T waves are starting to turn into a biphasic pattern. You recall that's referred to as Wellens. And maybe in V3 and V4, they're starting to rise a little bit. And then about 15 minutes later, now she's got ST segment elevation, V1, V2, V3, maybe a hint of it in V4. At this point, the EKG machine finally called it an acute anterior wall STEMI. The formal cardiology interpretation called this EKG and none of the prior ones acute anterior wall STEMI, and the patient went right up to the cath lab and had a 100% LAD lesion. And the first thing that showed up in this patient that was acutely ischemic was nothing more than simply that new tall T wave, larger than the T wave in V6, in lead V1. Let me show you another case. Case number 2. I've got about 6 to 8 of these cases. I'm only showing you a few of them. 89-year-old woman came into the emergency department for what looks like and sounds like a TIA. She's got some cardiac risk factors. And here's the initial so-called admission 12-lead EKG. Pretty much unremarkable. She's got maybe voltage criteria for LVH, but there's no signs of acute cardiac ischemia here. This is her admission EKG. She's got no chest pain or cardiopulmonary complaints, and her TIA symptoms had, by definition, resolved already. So she gets admitted to the neurology service, asymptomatic. Well, the night that she got admitted, she had a brief episode of chest pain. So the intern on call got a 12-lead EKG. Here's the 12-lead EKG during her chest pain. Notice a new upright T wave in V1. Let me go back to the admission EKG once again. It's normal looking T wave is inverted. Now she's got chest pain on the night of admission. She's got a new upright tall T wave in V1. T wave in V1 is larger than T wave in V6. Marriott calls that loss of precordial balance. However, the machine doesn't know about this, and the formal cardiology interpretation and the intern all call this normal, no significant change. So there was no cardiac workup that was done. She finished up her neuro workup, ended up being discharged, and I met her when she came back to the emergency department 4 days after her neurology discharge with chest pain. And this EKG, she collapsed in her bathroom, had some chest pain. She came back, and this is her EKG. Well, this is a no-brainer. She had a huge anterior wall MI. Unfortunately, she ended up going into cardiogenic shock and died within a couple of hours of this 12-lead EKG. But you just wonder if 4 days earlier, somebody had picked up on that subtle new upright tall T wave in V1, whether her outcome could have been very different. Again, it's a type of hyperacute T wave that tends to be ignored because it's often isolated just to lead V1 and maybe in V2. I'll give you one more case. This is a real subtle one that I had a number of years ago. A 54-year-old man came in with what sounds like reflux, burning, belching, dyspepsia, diaphoresis. And if you've ever heard me talk before, you know that reflux is always a diagnosis of exclusion in any patient who has any cardiac risk factors. It's the most common misdiagnosis sitting on the chart for missed acute MI. So be very careful about calling things reflux, because especially in older patients, especially diabetics and women, they oftentimes present with reflux symptoms and they get misdiagnosis, reflux, and discharge. Anyway, I'm digressing. Back to the case and the EKG. It sounds like reflux. Here's the initial 12-lead EKG, and he was asymptomatic when he arrived. He took some Maalox, and who knows if that did anything, but now he arrives, and his initial EKG showed up here, and he's asymptomatic. Well, he's got an upright T-wave in V1. In this particular case, the T-wave in V1 is a bit smaller than the T-wave in V6. So Marriott would really not call this loss of precordial balance. The other thing is, we don't know whether that's a new upright T-wave in V1. We don't have any old EKGs on this guy. And besides, he's asymptomatic now. So you can't call something a hyperacute T-wave really if they're completely asymptomatic. So I didn't know what to do with this guy. So anyway, what we did was we just watched him, got some serial enzyme, serial EKGs, and I was trying to stall. And anyway, his indigestion symptoms returned, and the first thing we do when his indigestion came back was we repeat the 12-lead EKG, and what do you know, his T-wave in V1 is very, very subtle, but the T-wave in V1 has gotten bigger, and it's now clear that the T-wave in V1 during symptoms is larger than the T-wave in V6. Marriott's calling this loss of precordial balance. So a subtle change, but his T-wave in V1 is bigger than the T-wave in V6 now. It was not when he was asymptomatic, and that was enough for me to bring him into the hospital. I had to fight just a little bit to bring him into the hospital. They thought it was reflux. Anyway, the next morning, they got an EKG after he had some stuttering chest pain overnight, and here's his morning EKG. He's got clear-cut Wellens waves. He went right to the cath lab at that point and had a big LAD lesion. No surprise if you know what Wellens is. All right, so new tall T-wave in V1, especially when that T-wave in V1 is new and larger than the T-wave in V6. Now, there are a couple of normal variants. This is kind of a curveball I'm throwing at you. If you look at this EKG and you believe what I've been saying, you're really concerned about that T-wave in V1. It's way bigger than the T-wave in V6. But, you know, something is off about this 12-lead. Take a look at the R-wave progression. V1 has an R wave that's decent size. Then V2 and V3, there's no R wave. And then suddenly in V4, you've got a big R wave. How is it that you go from medium size to no R wave and then suddenly it's big? Well, the other thing to look at is whenever you see R wave progression that doesn't make sense, consider the possibility of misplaced leads. And how do you know? Take a look at the P waves. P wave in V3 is inverted. P wave in V2 and V4 are upright. That doesn't make sense at all. Well, what if we took V3 and switched it with V1? Well, you know what? That would make sense now. And that's exactly what this was. This was simply misplaced leads. Lead V1 and V3 were reversed. And when you put them back in normal place, well, now the T wave in the true V1 is inverted. So this is just a normal variant. It's not even a normal variant. It's simply misplaced leads. There are a couple of normal variants to be on the lookout for. So you can get a tall T-wave in V1 if somebody screwed up the lead placement. Just put them back in the proper place. But left bundle branch block often will give you a big T-wave in V1. That's completely normal. Significant LVH can often give you a big T-wave in V1. That also is completely normal. Young people, especially young athletes with high voltage, will oftentimes have big T-waves in V1. That's completely normal also. But if you don't have misplaced leads or LVH or high voltage or left bundle, if you don't have any of those four possible normal variants, when you see a big tall T-wave in V1, especially if it's new and especially if it's larger than the T-wave in V6 in somebody with acute symptoms, consider the possibility that that person has acute cardiac ischemia. I'm not saying you're going to activate the cath lab because they don't qualify for cath lab activation without ST elevation. I'm not saying you need to call cardiology and tell them you need to take them to the cath lab or thrombolyse these patients. But the one thing I will say is consider the possibility of acute cardiac ischemia. Consider that this is a variant of hyperacute T waves that's localized just to lead V1, and that means that you've got to worry that something is evolving. So when you see this scenario, new upright tall T waves in V1, do yourself and the patient a big favor, get some serial EKGs and look for the possibility that that patient is on their way to developing some more concerning findings and a more diagnostic EKG, perhaps even a STEMI, as you saw in a couple of these cases. All right, so pay attention to those T waves. I love the T wave. I love the T wave because people never pay attention to it. And if you do, you're going to pick up some of these subtleties that other people tend to miss, and your machine will miss as well. So, new tall T wave in V1. Marriott called it loss of precordial T wave balance. Pay attention to those T waves. I hope that was helpful, and I'll talk to you next week. Thanks again to Andrew Bowman for sending that case to share with us. Take care.